Hi, my name is Terry Pannkuk, and I'm going to show a Heather-Say Type 3 resorption case on a maxillary first molar. Now, I routinely will take a periapical radiograph, but if you notice the bite wing, it shows a better view of the resorption defect. Even better is the cone beam CT, where we can get the actual 3D geometry and measure our angles and distances to the defect, which are extremely helpful as we begin access and triangulate for an internal repair. Now, this is the initial access with penetration of the mesiobuccal pulp horn. This is clearing the pulp space and passing a file through the DB canal system to see if it's patent through the resorption area. You will notice that there is a thick attached pulp stone to the pulp chamber floor. In this view, I'm extending the access towards the mesiobuccal line angle and removing some of the pulp stone. Once extending the access and clearing the pulp chamber floor, the resorption defect is revealed. Before addressing the resorbed area, the other root canal systems are completely cleaned and shaped. Next, the resorbed area is prepared and treated with 90% trichloroacetic acid. This allows you to find the DB canal orifice, which will then allow you to clean and shape it completely. After treating the resorption prep and cleaning and shaping all the canals, you can place calcium hydroxide and then a temporary. After taking off the rubber dam, you'll notice an expression of calcium hydroxide. The excess was cleared away and then cabot placed to seal the area externally. It's more favorable if the resorption defect does not communicate through the sulcus. In the video of the second visit, which was 1 month later, we'll show you how we dealt with it. We are now showing the second visit 1 month later after the root canal systems have been cleaned and shaped except for the distal buccal canal system, which involves a resorption defect. In this video, you'll see a paper point drying out the distal buccal canal, which has been cleaned and shaped. The resorption defect is quite dry after a month of calcium hydroxide and the treatment of 90% trichloroacetic acid. A lot of people have asked me, how do you fill the apical portion of a canal with coronal resorption without getting the gutta percha and sealer into the resorption prep? Well, the answer is carefully. You can do this by coating the apical end of the gutta percha with a light coat of sealer, placing it, being very careful, searing it off at the orifice at the level of the deepest portion of the resorption prep. And if you have good direct line access, it's actually not that difficult. So you can see I placed the cone with the sealer, careful not to spread sealer around the periphery, and now I go through the sequential downpacking with the multiple waves of condensation. You can see as I progress apically, I'm taking small bites of the gutta percha, removing them without trying to do too much at once so that I don't spread the material out to the periphery and into the cleaned resorption prep. One thing you'll note is a tentacle of resorption space coursing alongside the distal buccal canal that was a little bit perplexing to me. You'll note I was playing around with it, and as I compressed the gutta percha into the DB canal, I noticed it expressed out with some sealer, and I eventually just filled this space in with the gutta percha and sealer also, even though it looked like there may have been some, external communication outside the root in this area. It seemed like a limited area of involvement. So I packed that off solidly, sealed it, and the biodentine is going to be placed in the peripheral larger communicating opening. Now, why was this area perplexing to me? Well, I had two options. One, I could fill it with gutta percha and sealer, or two, I could have packed the gutta percha down deeper and maybe filled this area with a bioceramic like endosequence with better flow that would have coursed down the tentacle. So sometimes, I struggle with these decisions. It may be an equally valid option. In this case, I chose to fill it with gutta percha. In another instance, I might very well decide to fill it with endosequence flowable sealer. I really think the best option for that larger and more coronal area of resorption is the biodentine, because the strength properties of biodentine are more favorable. Here we are with the DB canal system pretty much obturated and sealed to the level that I want it to be, and we're starting the cleanup process. Here you will note I've flooded the pulp chamber with chloroform, and we're going to wipe away the excess gutta percha by solubilizing it and cleaning up the walls with a small micro brush. And then as we do that, we'll rinse with alcohol and scrub that to remove the excess gutta percha. Disharden. So we'll just clear up the periphery, clearing it with the alcohol. And that'll give us a relatively clean wall and clean pulp chamber floor. And most importantly, I'm looking at the resorption crypt to make sure that that's clean and clear of any remnants of the gutta percha. So I'm still clearing with the alcohol. You can see there's a little stream of gutta percha there. We're going to pick that away. Now that it's a little bit hard, it's not gooey, from the couple rinses of alcohol, we'll be able to kind of pick that clean. I'll use several different fine instruments, including Explorer, and just kind of scrape that around and remove it so it's clear. We're now mixing the biodentine and the triturator, and we'll deliver it with an amalgam carrier. Biodentine can have a very interesting consistency, and when you first place it, it may appear dry, but once you touch it and manipulate it, it starts to look more wet. If you vibrate it with an ultrasonic tip, it'll disperse and flow without voids very nicely. You can see at this point I placed it with the amalgam carrier, and then I packed it down with a Schilder plugger, and then I introduced the ultrasonic tip on low power, usually about a 2 setting, to disperse it and eliminate voids, then repeat packing it and alternating using the ultrasonics back and forth with the plugger until it's formed and packed into the resorption defect completely. I don't mind a little bit of overfilling with the biodentine. In this instance, we still have a very thin layer of the cavit that it was placed externally at the first visit, and so that kind of contains the biodentine so it won't express grossly out the external defect. Now the next thing I'll do is I'll have my assistant place a ball of cavit on a 12 plugger and pack that over the biodentine, compressing it down. But it's very important to have a thin layer of cavit covering the biodentine, because it's known that if you etch and bond at the same time you place the biodentine, it disrupts the set and integrity of the biodentine. You don't want to etch bond and place a resin directly over the biodentine. Cavit is a very effective and acceptable base material to place over the biodentine before you etch, bond, and place a composite resin. At this point, I'll go ahead and add more chloroform to the pulp chamber space, clear the gutta percha, clear excess cavit off the walls, then add some more alcohol, and then I'll do some sandblasting after rinsing this clear to really micro etch the surfaces of dentin in preparation for the etch, bond, and placement of the resin material. I place a UV shield over my microscope lens to make sure I don't scratch it when I do the micro etching. So I basically just etch until I make sure that all the debris is off the walls, and especially the cavous surface margin of the prep. There you can see the sandblast particles, in the soft surface layer of the gutta percha and the cavit. At this point, I temporarily take the shield off for visibility, place the phosphoric acid, scrub it in the pulp chamber, and then rinse it with the water thoroughly. Here I'm inspecting the access prep. It's clean of all debris on the walls. The dentin looks nice and frosty, like it's fully etched. And I go ahead and place the primer. 5 coats. Well, in this case I'm using Photobond. Occasionally I use Optibond FL if the prep is not that deep. And then place Luxacor as a macrofill composite material. Light curing the bonding agent, the Photobond. It's a dual cure. And at the same time I'm having my assistant mix the Luxacor and place it in a needle tip Centrex syringe. And I'll introduce that in layers, covering the floor with a thin layer so that it shrinks back without a gap. And then I just kind of line it up the walls like the ribs of a boat so it'll shrink against the wall and have strength with some idealized dentin bonding. Place a more thin layer at the base and place it up another rib of composite up another wall. Light cure each segment. So at the very end I will overbulk slightly. We'll finish this up. Here I am doing the final planes to make sure it shrinks against the wall again. And light cure. And sometimes I'll mix 2 capfuls of the Luxacor because it tends to, as it starts to set, it doesn't flow very well. So sometimes you need 2 capfuls. I think I used 2 capfuls in this particular case. So the final, take off the shield, and now we just kind of use a large round burr to go ahead and flatten it down. Have a nice contour. And then after going ahead and contouring the overbulked Luxacor, I inspect it. Take the rubber dam off, and then we'll go ahead and check the occlusion. Now I'm looking at the side where that cavit was sealing the external communication, and interestingly, over a month the gum tissue had grown back over that external opening. Go ahead and check the occlusion. Occlusion is fine, and we're ready to go ahead and take our final radiographs. This is a periapical radiograph taken from a slight distal angle, which I routinely do on maxillary molars, and here's the straight direct angle showing the obturation. This video recording will be placed on the Pure Dental Learning website as a case submission, and I thank all those who support the Pure Dental Learning project.